Hi, everyone. I'm Nicholas DeVito, an assistant professor of medicine at Duke University, and I'm happy to present the preliminary results of first-line Botensilimab and Balstilimab optimization in microsatellite stable colorectal cancer without liver, bone, or brain metastasis, deemed the BBOpco trial. If you can't make it to our AACR presentation on April 21st in the morning, where we are poster CT184, then I hope you'll enjoy this presentation. So some background to start off. We know that microsatellite stable colorectal cancer has limited response to conventional immune checkpoint blockade, and the standard of care is serial lines of chemotherapy with appropriate biologics. Studies have shown that immunotherapy can be combined with chemotherapy and with bevacizumab, and there are no new or unexpected safety signals in the trials that are listed there. Botensilimab is an Fc-enhanced CTLA-4, so a second-generation version of drugs like ipilimumab that's designed to augment T-cell priming, deplete intratumoral Tregs, and activate antigen-presenting cells, thus being more able to act in cold tumors that the immune system is not already recognizing, which is the dependency for PD-1 therapy. A graphic there is kind of explaining in A what that looks like. And Botensilimab has demonstrated activity in patients without liver metastasis, as you can see from the Nature Medicine paper from a couple years ago. Whereas patients with even treated liver metastasis could have responses, but most of your responses were seen in patients that had either lung or lymph node metastasis. A phase 1b study that isolated patients without liver metastasis in the third line, so after FOLFOX and FOLFIRI, or in the fourth line, showed that there's durable response, a 20% overall response rate, and improved overall survival versus historical controls. And this was presented by Dr. Schlechter last year at ESMO. So this brought up the hypothesis that we could potentially have better responses if we gave Botensilimab and Balstilimab, an anti-PD-1 antibody, earlier on in a select patient population. To test the hypothesis, we anatomically selected patients with microsatellite stable colorectal cancer that did not have immunosuppressive sites of disease, including liver, bone, or brain metastasis. The goal was to potentially negate the need for chemotherapy, given the durable response observed to BOT/BAL in later lines, or to meaningfully delay the need for chemotherapy. Our primary objectives were feasibility of both first-line BOT/BAL alone and in combination with FOLFOX plus the appropriate biologic as a rescue therapy. We also sought to evaluate the disease control rate and confirm the safety in this setting. Our secondary objectives include overall survival, progression-free survival, and PFS2 when patients cross over to standard of care chemotherapy. We also sought to determine the best overall response rate in both patients treated with BOT/BAL alone and those with crossover. Our exploratory objectives, which I think are one of the highlights of this trial because we can evaluate patients who are being only treated with BOT/BAL, and thus fewer variables are affecting their tumor, and we get a cleaner biological readout, is to identify tumor-mediated and immune microenvironment features that would predict resistance or response to BOT/BAL alone, and to develop future biomarkers with the goal of more accurate patient selection and novel combinations. We also drew blood over time, as you can see in our graphic there, to determine the utility of ctDNA and CEA as a dynamic biomarker of response to immunotherapy. As you can see, we enrolled 15 efficacy evaluable patients who had at least one scan. These are, again, our patients with stage 4 untreated microsatellite stable colorectal cancer with liver, brain, or bone metastasis. They could have been treated with adjuvant chemotherapy, but it needed to be at least 6 months before they were treated in the metastatic setting, and they could not have received any chemotherapy in the metastatic setting. We performed CT scans of the chest, abdomen, pelvis every 6 weeks, and if progression was observed, we obtained a biopsy to determine, again, those BOT/BAL specific markers of resistance, where there's no other therapeutics that could be clouding that outcome. And then the patient crossed over to FOLFOX, the appropriate biologic, and we were able to continue, in most cases, Balstilimab, and CT scans then went to every 8 weeks. So I'm going to show you some of our preliminary results now that are still maturing. What we observed is that there were 2 confirmed iRECIST PRs, so partial responses to BOT/BAL alone. This was in a patient with lung metastasis and another patient with peritoneal metastasis. Their TMBs were 1 and 3 mutations per megabase pairs, respectively, so there was no reason why we would think that they would respond to traditional immunotherapies. This is clearly something that is unique to botensilimab. What you can see there on the right is that we have several patients who had this prolonged stable disease, but then did need to cross over. Some patients who were clear non-responders, and then again, those two clear partial responses. Again, these data are preliminary, and objective response rate takes time to mature. We were able to recruit 15 patients in 14 months for this trial, so we're presenting very early and encouraging results, which confirm the feasibility more than anything of this approach. Here's our swimmer's plot, which is a cutoff of March 31st. And we anticipate to, again, add hopefully more responses over time as data starts to mature, as we've seen some very promising trends in CEA early on that I'll show at later meetings. Most of our patients have been able to stay on trial, and 5 patients have crossed over to chemotherapy for that are efficacy evaluable. And the median freedom from crossover to chemotherapy was 8.7 months, which I think is quite meaningful. So you have at least 2 patients who have already developed a confirmed partial response of our 15, and then you have a delay of chemotherapy in the 5 patients that have needed to cross over. And the disease control rate in this setting was 75%. This resembles the disease control rate to BOT/BAL alone, as you saw in the previous slide, which was also 75%. So nice disease control rate, feasibility of crossover is possible, and capturing some patients who are able to potentially delay or eliminate the need for chemotherapy. Now, I think seeing is believing, so some of our most impressive and interesting scans are kind of here. Patient 1 there is somebody who delayed their chemotherapy for well over 8 months after having an initial response to BOT/BAL and their peritoneal lesions, including like symptomatic relief. And then patient 2 is somebody who was featured in our Research Saved Lives segment at Duke, Spencer, and it can be seen there in the red line of CEA, where his CEA just absolutely plummeted and his lung lesions disappeared. He's, again, never received chemotherapy. He's only been treated with Botensilimab and Balstilimab. Patient 14 is one of those patients that is also a confirmed partial responder in the peritoneal disease that I mentioned before. Very encouraging disease control that we hope is durable. There are some CEA trends there. They are sometimes reliable, sometimes not. Most of our patients do not have detectable CEA, and there are more of these that will mature over time. I'm only showing the ones there that were on the study for more than 6 months. When we look at the characteristics of these patients, and I think this is something that needs to be really highlighted, is that the median age is 50. The median age for colorectal cancer in this country is 50. So this is a disease that's rising in young people, and we're offering them an option in the first line that could have the potential for temporary or long-term disease control and avoidance of chemotherapy. And we had a balance that you see there between sex, race, and ethnicity. Most of our patients received all their cycles of BOT/BAL. We had a distribution across lung, lymph node, peritoneum, and then a persistent primary. The vast majority of our patients had an ECOG of 0, and most of our patients were KRAS mutated. A couple patients had BRAF V600E mutations, but all of our patients were MSS, whole wild type, tissue TMB less than 10, and or plasma TMB less than 20. When we look at tolerability to BOT/BAL, the grade 1 to treatment-related adverse events are listed there, but overall they were quite manageable. We did not have any grade 4 events or anything that led to discontinuation of treatment or anything that was unexpected, I would say. I'll talk a little bit about our IRAE management and grade 3 toxicity, which was restricted to diarrhea and colitis, which immune-mediated diarrhea and colitis is expected with this class of agent. We managed this by giving patients a short course of prednisone to take home. And then if they developed diarrhea, they'd call us, and if it was on a weekend or at night or something like that, they could at least start the prednisone, and we tried to get them in for infliximab within 48 hours to steroid spare and favor the biologic for the management of IMDC. Early onset symptoms, which are primarily manifested by fever, were not uncommon, but we managed these with naproxen and ibuprofen. 3 patients additionally received a drug, leflunomide, for arthralgias. And one patient was treated with dose interruption and a prednisone taper for presumed immune-mediated hepatitis. So in total, since colitis was our most commonly managed side effect, I mentioned here that 9 of these patients were treated with infliximab. So I do think that this toxicity management of colitis is very important because it was something that we were able to address early because we had a plan to do so. What are our conclusions overall for these preliminary results that have matured only in 14 months for 15 patients? And there's a lot more that we have to learn from this trial and from hopefully future trials. We already know that giving bot/bal alone in MSS-CRC in the first line in patients without liver, bone, or brain metastasis is feasible. And we have some early evidence of durable clinical activity in a subset of patients and the potential to defer cytotoxic chemotherapy in others, as shown by the fact that we had at least 2 partial responses that are confirmed so far to bot/bal alone, and we have deferred chemotherapy by over 8 months in the patients who have had to cross over. And moreover, our disease control rate was 75% to bot/bal in crossover. So it's a very feasible overall approach to do this. And while the ORR and the PFS and the OS, of course, are early, and we're going to present these updates at later meetings and in publications, I think that this supports further biomarker-informed development of bot/bal in the frontline setting by itself via a phase 2 study in these patients. And then we can justify randomized study that incorporate endpoints such as time to chemotherapy, ctDNA dynamics, PFS2, to better capture the full value of early immune intervention. What's not listed here is we also have a strong interest in incorporating patient-reported outcomes, given the tolerability of bot/bal versus other treatments like chemotherapy, particularly in our younger populations. We're developing the use of ctDNA and, again, those tissue-based biomarkers that are primarily spatially oriented to determine response, and these will be presented at later meetings too, so please stay tuned for those updates. And the longer term goal is that we need to address non-responders to bot/bal, patients who don't respond at all or who exhibit stable disease and then subsequently do need to cross over to chemotherapy. I think our pre-post treatment biopsies that we're obtaining in a bot/bal only setting will give us an insight into how we can potentially manipulate that immunobiology to overcome resistance. And then we need to address liver metastasis, which affect half, if not more, of our patients with microsatellite stable colorectal cancer. Based on the exploratory objectives in this study and in a subsequent phase 2, along with our large Duke biobanking efforts that we have endeavored upon, and the development of organoids from human samples, and then finally work using mouse models in our lab that naturally metastasize to the liver and lymph node, we hope to overcome these obstacles in the future and then make immunotherapy an option for even more patients in colorectal cancer. So I largely have called this trial a foot in the door for microsatellite stable colorectal cancer with bot/bal. And to that end, I cannot thank our patients enough for going on this journey with us in embarking on a trial that seemed really risky to some at first, but made a lot of sense to a lot of people. And the thing that I am again proudest of is that we recruited 15 patients in 14 months. I'll also thank Gateway Foundation for Cancer Research, who funded this trial, which was also backed by our clinical research group in Crush Colorectal Cancer, which we host a yearly 5K for that gets bigger and better every single year. Thanks again to Agenus for drug support, as well as scientific advising, and to Eva Garland Consulting. My lab website is below, and I appreciate your time and attention to this trial that is novel and I hope changes care for our patients going forward.